Hi everyone, I'm Dr. Ng here. I'm going to talk to you about obstetric hemorrhage. Okay, again, the basic principles of handling obstetric emergencies are RESUS, R for recognition, E for early assessment, S for stabilization and resuscitation, U for urgent management, and also S for subsequent management or specialist referral or other special measures. But I'd like to highlight to you for obstetric hemorrhage. So you have to realize that all these steps has to be done simultaneously, and it is very important for you to communicate while assessing and resuscitate the patient. Okay. First, we're going to talk about recognition, which you need to know the definitions of different hemorrhages. This is quite worthy slides, so I'll straight away go through to the next slides. So you look at this timeline. Okay, from not pregnant, become pregnant until 24 weeks, until delivery of fetus, 24 hours after delivery of fetus, and 6 weeks postpartum. These are the landmark that you have to remember. Okay, mind you, for 24 weeks, we follow RCOG guidelines saying that APH is 24 weeks and onwards. All right. So before 24 weeks, any PV bleeding, we call it as miscarriage. Either threatened miscarriage, incomplete miscarriage, or complete miscarriages. For antepartum hemorrhage is any bleeding occurs after 24 weeks gestation. All right. After delivery of the fetus, when you have bleeding more than 500 cc, up to 24 hours, we call it as a primary PPH. Okay. If let's say the PPH occurs after 24 hours until 6 weeks postpartum, that is called a secondary PPH. All right. So why do we need to classify it like this? Because there are different causes. So when we look into antepartum hemorrhage, commonest is indeterminate APH, means we didn't know what are the causes. It can also be because of abruptio placenta, placenta previa, vasa previa, or because of local causes. All right, such as cervical erosion and all. Okay. So when we talk about PPH, PPH is defined as bleeding from genital tract more than 500, more or equals to 500 cc after delivery of the fetus. Okay, you subdivide into primary or secondary depending on when was the PPH. Okay, so for primary PPH, the 40s, famous 40s, tone, trauma, tissue thrombin. Whereas for secondary PPH, the causes are slightly different. Infection, which we call it as endometritis, not endometriosis, okay, or retained POC, or there's unrecognized genital tract trauma, or there's underlying bleeding disorders. A less common cause like persistent trophoblastic disease, AV malformation, or chronic subinvolution of uterus. So we have talked through you about the definition. You have already recognized, yes, this is a bleeding, and I think this is an antepartum hemorrhage or a postpartum hemorrhage. Now you need to assess the patient quickly. Why you want to assess? Because you want to know the severity and the causes of the bleeding. So first we talk about severity. How do you assess the severity? You can do by visual estimation. You can do it by having a clinical signs and symptoms to show that it is a hypovolemic shock or not, or you can assess via this obstetric shock index. Okay, before we go further, we need to know whether this is a minor PPH, a major PPH, or a massive PPH. Huh? So when the bleeding is 500 to 1000, we call it as a minor. If let's say it is major, we call it as more than 1 liter. If it is massive, if you follow guideline says it's 2000, but in Sarawak we take it as 1.5 liters. Okay, so this is how you visually estimate the blood loss. Okay, this is very important. You have to remember. You will find this pictograph in the labor ward. Okay, so one pad is fully soaked is 100 cc. One kidney dish fully is 500 mils. Okay, all right. And the linen protector, so a quarter is 500 cc, half soaked is 1 liter, almost fully soaked is 1.5. And you look at the sarong. Okay, the sarong, if half soaked is around 400, fully soaked is 700 cc, and a vaginal pack is 80 cc. So these are the common things that we use in labor ward. Okay, Next is about this class of hypovolemic shock. Okay, why is this important? Because sometimes you do not see the patient come and tell you, oh, she bleed at home, but cannot quantify. So how are you going to visually estimate the blood loss? This is how you can classify the stages of shock. Okay, so remember the blood volume for a normal human is 70 cc per kilo. So let's say you are 40 kilo, your blood volume is only 2.8 liters. But if you are 100 kilo, your blood volume is 7 liters. All right. So you need to know what are we looking when we talk about classification of shock. So you need to know whether the heart rate, the blood pressure, you look into the respiratory rate, mental status, and the urine output. Okay, so it seems like a lot of numbers to remember, but remember the tennis score. So when we play tennis, we play the score will be 0, 15, 30, and 40. So this is 15, less than 15% is stage 1. 15 to 30 is class 2. 30 to 40 is class 3. More than 40 is class 4. This is very severe. Okay, all right. So you look, one of the trick to remember is you look at the heart rate. Okay, if let's say it is less than 100, so usually it's class 1. But if let's say it is more than 100, then you need to see 100 to 120, so roughly around class 2. If let's say it's 120 to 140 is around class 3, and also more than 140 is around class 4. And blood pressure is never the first parameters, okay? So if you look into it, heart rate and urine output and mental state. Actually, the first thing to change is respiratory rate. If you realize a patient become more tachypnic when they have PPH, that is because when you lost blood, then you have hypoxia and you will have tissue acidosis. So that is how, this is actually the first sign. Respiratory rate is the first signs of deterioration. Okay, so before your blood pressure go down, if let's say you have a patient with hemorrhage and the blood pressure is less than 90/60, then you are in trouble. This patient is at this category already. Okay, so if the blood pressure is normal, don't be too happy. You need to look into respiratory rate and also the heart rate. All right. So I want to show you an example. So if you have a 40 kilo patient, patient A, and a patient B is 80 kilo. So your blood volume in patient A will be 2.8 liters because 70 times 40, right? So it's 7,428, 2.8 liters. As for patient B, you have 5.6 liters. Okay, so both of them lost blood of one kidney dish and also a quarter linen protector. Okay, so one kidney dish is 500 cc, a quarter linen protector is around 500 cc. So it's around 1 liter lah. So if you calculate, okay, 1 liter in a 2.8 liters blood volume is actually a 35% loss already. Okay, whereas for this 80 kilo patient is only 17. Okay, 17 is around class 2, and then 35 is already class 3, 30 to 40% shock. Okay, so you estimate that, you anticipate that the blood pressure will be reduced for patient A, heart rate will be 120 to 140, the patient will be confused, and the urine output will be reduced. Okay, so not to say the respiratory rate will be increased. This one also respiratory rate will be increased, but the blood pressure will be relatively normal, slightly tachycardia, a little bit anxious, urine output slightly reduced. Okay, so this is the difference in between 1 liter of blood loss in 2 different patients. Okay, so you need to know, so for this patient it's more severe. All right, although both of them bleed 1 liter, but this one bleed 35% of her blood, but this patient only bleed 17% of the blood. All right. Next is, if you have a patient, she's a para 5 post SVD, during 1 hour post delivery, you noted that the heart rate is the BP is 80/60, heart rate is 150, she's drowsy, she's pale, and the janitor has just came and changed the linen and discard all the yellow bin. So how are you going to know how much is the blood loss? All right, so I have told you, right, this is a stage class 4 hypovolemic shock already, because you see she's hypotensive, she's tachycardic, she's drowsy, she's pale, So at least more than 2 liters of blood loss already. So you no need to go and dig the yellow bin again to count one by one. That is why you need to know all 3 methods of estimating blood loss. Okay? So next, again, you have a patient. She's a primate at 32 weeks with underlying preeclampsia. So she has painful pervaginal bleed. Bleeding was a quarter pad at home. So when she comes, she is pale, she's drowsy, her BP is 100/60, heart rate is 140. EBL quarter pad 25 cc. Okay, so you need to be careful because this patient has preeclampsia to start with. So preeclampsia means the patient has high blood pressure to start with. So when she loses a lot of blood, this is a concealed abruptio, then this blood pressure is actually low for her. So it is not normal. Okay, and you also have to be very careful, especially in antepartum hemorrhage. The actual blood loss is not equals to what you see. Okay, you will always underestimate the blood loss. All right, so this is why, apart from visual estimation, you also need to know about the category of shock and also need to know how to estimate blood loss through looking into the vital signs and physical examination. Okay, next I'd like to talk to you about obstetric shock index, OSI. A lot of words again. So OSI basically means heart rate divided by SBP, systolic blood pressure. Okay, if it is more than 1, it is not good lah. But no need to use calculator. You just simply need to look into this. Alright, so this is when the heart rate become more and more tachycardic and the blood pressure come down slowly. Alright, if you realize if you have hemorrhage or bleeding, so the first response is respiratory rate, the next will be tachycardia. Alright, then only the blood pressure will drop. So sometimes when you are here, you will not notice actually the patient is pointing towards deteriorating end. So again, OSI is heart rate divided by systolic blood pressure. Okay, anything more than 1 is abnormal. Okay, so you need to be very worried if it is more than 1. So you look at this chart, you already know this is not good. Okay, next, your assessment, you'll need to know what are the causes. All right, what is the leading cause? So for antepartum hemorrhage, indeterminate APH means you cannot find the cause. So you need to rule out other causes. So the other 2 common thing is placenta previa or abruptio. Okay, you must be able to differentiate in between these 2. Okay, placenta previa, they come with painless PV bleeding, whereas abruptio is painful. Okay, previa, usually the bleeding is, you can see the bleeding is revealed, but abruptio, you have to be careful, it can be concealed. Okay, so for previa, the uterus is soft, fetal heart usually present, then they can have abnormal line or malpresentation. But for abruptio, the abdomen can be very, very tense. It's called woody heart. Okay, patient fetal heart might not be present, and it is difficult for you to feel the fetal part, and sometimes the uterus may be larger than dead. Okay, so for abruptio, there are 2 types. You can have a concealed bleeding. Concealed meaning that the bleeding is here and you cannot see, whereas revealed means the separation and the blood dripping out so you can see. Okay, so abruptio placenta means premature separation of placenta before delivery. So when the placenta separate, it cut down the blood flow to the baby, so therefore it can lead to intrauterine death. Okay, next is about vasa previa. Vasa previa meaning that the presenting part is actually the vessels. So what does it done? How does it happen is when you do ARM, then suddenly it bleeds profusely. So usually you need to take out the baby very fast and very high perinatal mortality. Okay. So for postpartum hemorrhage, the causes, I'm going to focus on primary PPH. So we talk about the 4 T's. Tone, trauma, tissue, thrombin. This is a busy slide, but you need to always go back to this tone, trauma, tissue, thrombin, the 4 T's. All right. So when you look at the patient, you need to ask yourself, does this patient have these risk factors or not? Antenatal, you are looking for anemia, whether this patient is a multiparity, grand multipara especially, whether the uterus is over distended or not. When it is over distended, after the baby come out, then they cannot work properly, they cannot contract properly. So these are those patients like those with polyhydramnios, multiple pregnancy, or macrosomia, or whether there is a fibroid to cause them to not be able to contract properly, or placenta previa. So intrapartum risks such as prolonged labor, you have been working for so long, you also fatigue. The uterine muscle also can be fatigued, they also refuse to contract. So other causes such as chorioamnionitis, your GA drugs, GA means general anesthesia drugs, or where the patient is on magnesium sulfate, or the other cause is like shoulder dystocia. And you can have, for trauma, you need to know the common risk factors are like instrumental delivery, because you can tear the vagina, you can tear the anal sphincter, you can have cervical tear, sometimes you can even have uterine rupture because of previous scar. All right. Next is tissue. You look into whether the placenta is complete or not. When a patient bleeds after delivery, you must always ask, first, placenta out already or not? Second, is the placenta membrane complete or not? Okay, because this you need to go and evacuate. All right. And then next is thrombin. Thrombin is the least cause. So unless those patients that who are known to have some coagulopathy, or they just jab their placentate like 1-2 hours before, or they are on warfarin and they suddenly come in labor, okay, or they already developed the IVC when they have antepartum hemorrhage, then these are the causes of thrombin. Okay, so on examination, how do you differentiate in between these 4 T's? You look at, first you ask yourself, placenta come out already or not? If placenta hasn't come out, then you know it's tissue lah, all right, membrane ragged or not, okay, so then you know it's tissue. Okay, then you palpate the uterus. Is the uterus contracted or it is lax? Is it larger than 20 weeks? Is it above the umbilicus? All right, so if it is lax, then you know it is because of uterine tone. Okay, then trauma, you look at you have to examine the genital. Okay, so when you examine the genital, always remember, do it in a systematic way. Look at from the clitoris on top until the below at the foci. So clitoris, labia minora, labia majora, and the foci. Then from inside to outside, cervix, vagina wall, and also then you come out to the introitus. All right, do it in a systematic way, so that you will not miss any tear. Okay, so if you have seen everything also normal, but the patient just continue to bleed and bleed everywhere, then you know that it's because of thrombin. Okay, so we have already know that this is a bleeding. We have known which kind of bleeding, whether it's an APH, PPH, primary or secondary, and we have already quickly assessed the patient, or whether very severe, major, minor, or whether this is because of what are the cause. Then you now need to stabilize and resuscitate the patient. Okay, no matter which posting you go, no matter what emergency you have, you always come back to this rule of thumb, DRS ABC. Okay, so what does DRS ABC means? Danger, response, shout for help, airway, breathing, circulation. So this is always back to the basic. Danger, you need to see whether the patient is in a proper position or not, or whether the patient is in a proper place. Is there anything that endanger you? So now, as in a COVID pandemic, if let's say the patient is a PUI or COVID positive, you need to wear your PPE first. Then you go in and assess the patient and resuscitate the patient. Okay, respond. Call the patient. So and talk to the patient. When the patient can reply to you, means the airway and breathing is normal. When the patient is unresponsive, yes, the airway and breathing might be compromised. Okay, then you shout for help. So to shout for help, you need to know, is it true that all PPH has to call for red alert? Not necessary. It depends on how is the situation, whether the bleeding is very fast, or whether the bleeding has already stopped, or the patient is unresponsive. Then you need to call for help very fast. You need to call red alert. Okay, so for your level, you need to call for help. To get more personnel, you need to get your MOs, your other colleagues, to come and help you, especially in bleeding patient. Okay, so airway, breathing, as usual, I'm not going to talk much about here. Circulation will be the important parts here. Okay, you need to secure 2 large bore branula. So large bore means 14 gauge and 16 gauge. Okay, so go to the label ward and find out what is 14, what is 16. Okay, then the blood, you need to syringe out some blood. All right, Ideally is 20 cc. If you can get 10, full blood count, coagulation profile, GXM, and electrolytes. Okay, so need to decide this is an emergency situation that you need to call for red alert or not. Okay, so the what are the common situation that you need to call for red alert? Number one, patient is not responsive. Number two, the bleeding is very profuse, very fast. Number three, patient's vital sign is abnormal. Patient is already in class 3, class 4 shock and still bleeding. Yes, you need to call for help. You need to call for red alert. All right. So how do you stabilize the patient? So this is just common sense. Number one, when you have a patient is bleeding, you need to quickly replace the fluids in the body. So when you replace the fluids, you did not stop the bleeding, then how? It will become like this. All right. So resuscitation. Okay, when we talk about fluid resuscitation, so we need to replace the volume in your body, your blood volume. You have red cell, you have plasma. Okay, so when you lost your blood, you need to replace back with the volume. But remember, the fluids that we give is not equals to whatever blood that we have, and blood will also take time. So how much fluids, how fast to give? Okay, number one, we always start with crystalloids. Crystalloids are things like Hartmann solution or normal saline. So the ratio is 1:3. Colloids is gelafandine. So after you have finished your normal saline, then you can follow up by gelafandine. So the ratio is 2:3. And then next will be blood. Okay, when you have lost like 30% of your blood, then you most of the time you actually need blood products, packed cell, to replace back. And sometimes you will need other blood products such as FFP and also cryo or platelet. Okay, then you also need to monitor the output. Okay, you infuse fluids in already, then you need to monitor how much is coming out. You do not want to overload the patient. You need to provide oxygen. You need to also monitor the mother or the baby if the baby is still intrauterine. Okay, so crystalloids, what do we mean by 1:3? Okay, so let's say you have 500 cc of blood loss. So 1:3 ratio means 500 times 3. So it's 1.5 liters of normal saline. Okay, so similarly, if you have 1 liter of fluid loss, blood loss, then you times 3 is 3 liters of normal saline. And how fast should you give them? You cannot give this over 24 hours because the patient is bleeding like 1 liter bleed over 15 minutes. If you're going to replace this over 1 hour, 1 day, how are you going to catch up? All right, so you need to infuse as soon as possible. Okay, so whereas for colloids, what does it mean by 2:3 ratio? So if let's say you have 1 liters of blood loss, so it is equals to around 1.5 liters of gelafandine. Okay, so you can give up to 3 liters of crystalloids and then 1.5 liters of colloids, and then your blood product should be here already. This colloids is just buying time, or is a volume expander. It's just buying time for blood to come, because even emergency cross match you need around 30 minutes time. Okay, you need to get to know about massive transfusion protocol. All right, I'm not going to go through too details. So when your MO said okay, activate massive blood transfusion protocol. Also, especially if you realize here shock index is more than 1, is already an indication. So you can ask your MO, or do we need to activate a massive transfusion protocol? If they didn't tell you, okay, it's also called as MTP. All right, so you notify the blood bank. So you need to pay attention here. You need to bring your EDTA tube, your GXM forms, and also your transport box. Okay, you need to get the patient details correctly. Okay, so while you were waiting for the blood, what else you can do is you can get SAFE-O and also IV tranexamic acid. You have to remember the SAFE-O here is not a O negative blood. Most of the time the SAFE-O is actually a rhesus positive blood. So if let's say the patient is rhesus negative, you have to be very careful. All right. Then next, so the NTP pack will include, O means packed cell. So usually it's packed cell, and then your FFP, cryoprecipitate. Or then next you will have includes platelet, because by the time you have given this blood, the patient has lost so much of blood, patient tends to go into DIVC. So this is to correct the DIVC. Okay, all right. So after you have after the patient bleeding has been secured, patient is stable, you need to remember to deactivate the MTP. Okay, so the aim I'm going to talk to you later. All right. Okay, so what is our aim in resuscitating or transfusing blood? So we aim the HP is more than 8, platelet is more than 50, or the PT-PTT ratio less than 1.5, or the fibrinogen level is more than 2. Okay, so you need to know about this, especially if you go for your MCQs or what. All right. So after you have stabilized and resuscitate the patient, you also need to stop the bleeding. That is where the urgent management come. Okay. So to control or secure the bleeding, you need to secure it immediately or temporarily when you want to transfer the patient. This is only if, let's say, you are in district hospital without specialists, then you need to transfer the patient over. Okay, remember IV tranexamic acid, okay, 1 gram is 10 mils. No need to dilute, just syringe out 10 mils and then give over 10 minutes. All right. For patient with antepartum hemorrhage, you need to ask first of all, not all antepartum hemorrhage is equals to IV tranexamic acid. You can consider to give, but if in all types of PPH, no matter of which T's it is because of, you can actually give the tranexamic acid. Okay, if they still bleed after 30 minutes, you can give a second dose, or if they bleed again within the 24 hours, you can give the second dose. So for antepartum hemorrhage, how are you going to stop the bleeding? For placenta abruptio is delivery lah. So the mode of delivery will depends on the severity, the fetal viability, and also the labor progress. Placenta previa, definitive management is Caesar. Okay, it also depends on how much is the bleeding and how premature the baby is. Okay, and local cause you can do some vaginal packing and all. All right, I'm not going to talk into detail about APH management. Okay, so I would like to highlight to you about postpartum hemorrhage. Tone is the commonest cause of PPH. You must know in and out about this. All right, so what you can do is you can massage the uterus, you give the tranexamic acid, you need to give your ostetotic drugs. You must know your ostetotic drugs in and out. All right, so the ostetotic drugs that you can give is either a IM pitocin 10 unit or a IV pitocin 5 unit. All right, so if it's intramuscular is 10 unit, intravascular is 5 unit. All right, okay, so this is on top of the pitocin that you give after delivery of the shoulder of the fetus. That is called active third stage management. That is preventive. This is therapeutic treatment. Okay, then you also commonly see IV PIT 40. So this is oxytocin 40 unit in 1 pint normal saline. Then you run at 125 mils per hour. Okay, or you can also give another symptometrin, a repeated dose. So the first dose is given for active third stage management when the fetal shoulder was delivered. But then if let's say she has PPH, you can repeat another dose. But the contraindication for symptometrin is heart disease or hypertension. All right. Next is carbopros, which is a hemabate, is a prostaglandin 2F alpha. So the dose is 250 mic or 0.25 milligram. You can repeat every 15 minutes, maximum 8 doses. Okay. So usually if you give until the third dose is still bleeding, you need to think of some other methods already. So you no need to give until number 8, then only you find other methods. Okay. Next, this is medical. How about surgical? Surgical, you can try uterine tamponade. You can put in a Becquerel balloon, or you can do a bimanual compression. The bimanual compression is just temporary measure. Okay. This is how we do a bimanual compression. So your hand go into the vagina. Okay, don't touch anything. Make it as a fist. All right, put it under anterior fornix. Where is the anterior fornix? So you can see this is the anterior lips. Push it there, and then lift the uterus towards your fist. Okay, use the other hand on the abdomen and lift it. So this is bimanual compression. The other thing that you can do is aortic compression. So umbilicus left 2 cm, higher 2 cm. So you put your fist there. Then you feel the femoral pulse. If the femoral pulse is not there, means your compression is correct. All right? These are temporary measures. So this is how a Buckley balloon looks like. Buckley balloon we can put in for 12 hours, 24 hours. Okay. It is good if you know how to insert a Buckley balloon, but I'm not going to talk into detail. Next is the other causes of PPH, which are the trauma, tissue thrombin. So if you have trauma, you need to repair lah. Okay. So if you cannot see, then you repair in OT, examination under anesthesia. Okay. If you really cannot and do know how to repair, pack and then refer early and resuscitate the patient properly. Okay. So for tissue, if let's say there is retained placenta or retained cotyledon or membrane or what, then she might need a MRP. Okay. If it is thrombin, you need to correct the coagulopathy, meaning that you need to transfuse her with FFP, platelet, or cryoprecipitate. Okay, so it's actually not very difficult. So you go back to the basic principles. Next is about subsequent management, specialist referral, and also special measures. So basically, it depends on what are the causes of the bleeding. You want to stop the bleeding, and then you want to consider how to transfer the patient. Not so much about your daily practice. You need to know how to monitor and what are the investigation to send and when to trace and what is the aim. And you also need to know about documentation. So these are the things that you need to monitor the patient. We have an SOS chart which includes the vital signs. You also want to know the pain score. You want to monitor the input-output properly. You have to optimize the HB, coagulation profile, and the ABG. So the therapeutic aim, as I mentioned to you earlier, okay, sometimes you may need to start the patient on noradrenaline and she might need an ICU care. This you must know. It's available in the labor ward. This basically is a summary of what you have done to resuscitate the patient. Okay, so who has been called? Was there oxygen? Was there Branula? Okay, then what is the observation? BP pulse rate? What are the fluids that has been given? Bloods has been given. All right, CBD or not, GXM or not. So the medications is also here. Okay. Last few things that I would like to highlight to you is about communication. So when you want to refer, when you are doing your shift work, let's say you are in Med 3, so you are the only houseman and the patient is bleeding and you are very worried, bleed a lot, then you want to call for help, then you pick up the phone and call your MO. Okay, be precise and tell what is happening. Use this SBAR, okay, situation background assessment recommendation. Okay, so tell your MO, I am so and so, I'm houseman from Med 3, calling for help for a patient with PPH. I'm telling you the situation is a PPH, then your MO will alert. Okay, this lady is a para 5, post delivery how many hours? Okay, was noted to have what or any other underlying background that is important. History of miscarriages, history of APOC, do know 10 years ago is not important already. You tell me the risk factors, okay, that can contribute to the PPH. Okay, so again, I am Dr. So and so, the houseman in Med 3, calling from Med 3 for a PPH. This patient is Madam A, para 5, post delivery with a pair of twins, 5 hours, and noted to have excessive blood loss. Okay, assessment. What is your assessment? She is currently pale or pink. Okay, her vital signs are as such. I think this is a class 3 shock, class 3 hemorrhagic shock. All right, and the EBR is around 1.5 liters. So I have already set line. I'm calling for help. I am giving her pitocin. I am giving her a cross-match blood for her. I have run fluids, so it go back to your DRS ABC. I have given her oxygen, so I will need your help for further resuscitation. Then your MO will be very happy to come and run here. Okay, so on top of that, you can say you have given her IV tranexamic acid. Rather than, I am Dr. So and so, I have this patient, she is for 30 years old, para 5, she was admitted 3 days ago for induction of labor because she has a twin pregnancy, and then you tell me the story for two minutes already that I didn't know the patient is actually having a PPH. Okay, so it is very important in communication in emergency situation. So as a summary, you need to know what is happening, you need to know what kind of hemorrhage this is, and then you need to quickly assess severity and the cause. You need to stabilize and resuscitate the patient, and you need to arrest the bleeding, and the further management depends on what is the cause. Okay, all this has to be done simultaneously, and it's very important to communicate. Okay, so this is just a summarize again. So you recognize and assess, see how much is the bleeding. So whether it's by estimation of blood loss by your eye, or you can see the vital signs, okay, and the patient's symptoms, or you can look at the obstetric shock index, and then you want to find out the cause. Okay, then you want to call for help. How much help do you want to call? Okay, then you want to resuscitate the patient. So DRS ABC again. Okay, set line, run fluids, okay, get blood, as simple as that. And then you want to give treatment. You want to give tranexamic acid first. Then you want to see what are the causes. Is it tone, trauma, tissue thrombin? And your further management will depend on which kind of cause. If tone, you have to remember your oxytocin drugs. Okay, trauma tissue, most of the time you have to go to OT. Thrombin is about coagulopathy, you need to correct it. And then you need to monitor the patient vital signs. Okay, so during active bleeding, every 5 minutes. After the bleeding has stopped, for the first 2 hours, I think 15 minutes. Okay, all right, and the patient has to be on SOS chart. You need to monitor in and output, and also the vital signs. Okay, so that's it. Thank you very much.